Yeah, guys, look please here. This is the deep ring of some canal, yeah, which we call femoral canal. Now, what is, I will use it, then I will give you, okay, this depends. 2-3 minutes. It's not here. Now look, please, guys, what is covered this ring from upwards? Now, use your imagination and imagine, please, that it is covered by two structures. First of all, it is endo-abdominal fascia, which is continued to the pelvis and become to the pelvic fascia. Yeah? By the way, endo-abdominal fascia, which is covered this ring, it is perforated. Why it is perforated? Because here we have the lymphatic nodes. And the vessels of the lymphatic nodes come to the abdominal cavity. Yeah? They go upwards to be drained into the abdominal lymphatic nodes. That's a part of the endo-abdominal fascia, which is covered this ring, we call internal cribriform fascia. Fascia cribrosa interna. What is covered the fascia from upwards? Friends, it is more than simple. Parietal peritoneum. That is the floor of your peritoneal cavity. Peritoneal cavity is finished here. You understand me or no? This is the part of the peritoneal cavity which is located between anterior abdominal wall and the urinary bladder. Yes or no? You understand me or no? I think it's more than simple. Sorry, but canal should have minimum 2 rings. There is the second ring. I will draw, guys. Now look, this is my femoral region. We remove skin, we remove fat with superficial fascia, and that is the proper fascia. Proper fascia of femoral region. You understand that, Ahmad? Yes. Proper fascia of femoral region we call fascia lata, broad fascia. Now look, just on the level of the deep ring, it is medial third of the inguinal ligament, below the inguinal ligament. I will draw them one more ring, and then I will cut this paper one more time. And in the same time, I will open for you that picture. Do you see this ring now in this picture? No. Only Hamza see or everybody see? Do you see? Go to my picture and show you. Go. You're like Mike Tyson, but in white color here, in this cap. Please, where is this aperture? If you see it, then move by your hands. Yes, sir. I see it. Where is it? Why you look to them? Go now to your place, Fred. You have two chances, Fred. Look here, please. Chance number one. You will collect the problems during your educational time. Now you go by that way. Chance number two, if you will change yourself, you will collect the knowledge. Now, I see that knowledge is not important for sit down. Don't show yourself. Now look, please here. This is, of course, the aperture, which I mentioned before. This is the femoral region. Skin and fat is removed. And you can see that in proper fascia, there are defects. This defect, I modulate it now by this paper. By the way, it is located generally in the frontal plane. If previous one located in horizontal plane, mainly, that is located in frontal plane. Yes. And we call it hiatus saphenus. I think from anatomy you remember, hiatus, it is door, aperture. Saphenus, it means superficial. Why superficial door? Because the biggest superficial vein of human body, which is called vena saphena magna, come to this aperture, and through this aperture, drain into the femoral vein. This aperture located here. Proper fascia cover this femoral triangle, and through this aperture now, the vein is come and drain into the femoral vein. By the way, this aperture also covered by remnant of the proper fascia, which also perforated. Why? Because you see vessels is passing. And we call it fascia cribrosa externa. Let's say internal cribriform fascia cover the deep ring, external cover the superficial ring. Upper and lower margins of this aperture, you can see it here, is very thick. Again, from anatomy, you remember, maybe, I wish to this, but I'm not sure. We call it cornu superior, cornu inferior, horns, superior horn and inferior. And the margins between them is very sharp. We call falciform margins, margo falciformis. There's a superior horn, inferior horn, and sharp margins, margo falciformis. After you will see why it is important. Just now remember. Okay. Now what am I here? I have I have two rings. But sorry, where is the canal between them? No canal, friends. No canal, because normally nobody doesn't have femoral canal. But we have these two rings. What does it mean? It means normally we don't have this communication between these two rings. If we don't have, why we describe this canal? Simply. Now imagine that this weak place stands weaker, deep ring. And some organs from peritoneal cavity descended inside of this ring. By physical rule, they will try to find a place with low pressure, and it will be superficial ring. That's I remember forever, right, or what do you want to do, I don't know. Femoral canal originated in the time of the herniation, together with femoral hernia. That's why this is pathological, not normal anatomical structure. If your inguinal canal is absolutely normal, and everybody have it, femoral one, no. Femoral one originated during herniation. That is very important, remember it, please. Now, Natalie, tell me, please, in your opinion, femoral hernia, mainly, that is male problem or female? Look, I show for you the structures. No, I want to listen first to your answer. Absolutely logically, you can try to answer in this question. Why?
Because for female, it's the...
It is bigger.
Wider.
It is wider, and not for simple females. That is females with many pregnancies. Many, we means 3 more. And females usually after 50, 55. Now explain me, Ahmad, why for females after 3, 4 pregnancies, after 50, 55, this aperture will be enlarged?
Why it's going to be enlarged?
Yes. I will open this picture, maybe it will help you.
Because the ligament will be weak.
Because the 1 minute look here, please. Pelvis size will stand wider, and the force of the inguinal ligament will be a little bit descended. It will be more loose. If it will be more loose, sorry, it is the border of this aperture. Aperture will be enlarged. But I tell you before, what is the cause of the hernia? Weakness of the weak place. So weak place stand weaker, bigger. The chance of formation of the hernia is increased. 99% of the cases, femoral hernias, it is female's problem. But more than 80% of the cases, inguinal hernias, it is male's problem. Because triangular aperture. For females, it is groove shape. For males, it is triangular. So remember about it, guys. You can say, what is the factors of formation? What is made weaker this place? I say you, pregnancies, physiological age of the patient. Because why age? Elasticity of tissues is lost. What will be predisposing type of the factors? High pressure inside of the, usually for that group of after 55, it's not so much active trainings in the gym, but much more you take something heavy, yeah? Or for example, due to the problems with gastrointestinal tract. For example, the problems connected with the passage of the content, yeah? If there are the different kinds of the problems. Yeah? Constipation, usually, but not only. Chronic or any inflammations, yeah? Or cough. Cough also increase the pressure inside of the peritoneal cavity. So it will be just a predisposing factor for formation of the problem. Now look to me. If the hernia will be formed, how many layers will cover the side? Fascia fibrosa interna, loose connective tissue with the lymphatics, fascia fibrosa externa. So you understand that the more layers cover, for example, inguinal hernia, especially oblique, doesn't cover. Direct covered by fascia transversa. But indirect doesn't cover. Yes. That's why here much more layers. Sorry, it will make hernia bigger or smaller. See that? See that? What about this speed?
Smaller.
Smaller. Why smaller?
More
Friends, imagine that you are walk, and in front of you there are several walls. Will it help you to walk faster or no? No, you will just damage your head. And like here also, the hernia cannot be protruded so much because in front of it we will have walls, natural membranes. Now imagine situation, the woman after 55 with 1 centimeter structure in the fatty tissue. Usually this woman is not so, no, can be slim or no, but generally not like 20 years old person. That is the cause why this small problem cannot be found usually, yeah, because it is not so big protrusion. By the way, if on slim persons, it can give the protrusion. And it is exactly visible that this protrusion located below the inguinal ligament, not above.
Yes.
If it will be inguinal one, it will be here.
Yes.
But
Below
it
the
is
natural fold.
greatly visible that this is inguinal ligament and this protrusion located below. Sorry, no, any inguinal hernia cannot give such kind of the picture. But if the person will be a little bit big, this small, you can see the protrusion is much more smaller than the inguinal protrusion. So the inguinal protrusions can be up to the ball size.
Yeah.
Not so big ball, but anyhow, ball size. This is the problem why approximately in 60–65% of the cases, first diagnosis we do for complicated form of the hernia, which is give the pill. Because then it is non-painful. Which hernia is non-painful? Not reducible one. If it is reducible, it is not painful.
Yeah.
But if it is very small, the woman will not find it, yeah? Usually, even if she will palpate something, she will think about inguinal ligament. Inguinal lymphatic nodes. Usually, she will think about lymphatic nodes. Maybe there are some small inflammation, but it's not painful. When it will start to give pain, then it will be complicated. Or to come to non-reducible or touch wood, it will come to strangulate. Let's say, remember, please, sometimes you say small hernia is better than big. No, guys, big hernia, it is visible, understandable. And the patient go to the hospital. And you can make the treatment in early stages, before complications. Such kind of the hernia can be blunt and visible. Now look here, okay, we find this hernia. You know, hernia treated only surgically. We don't have any drugs, pills, which can treat it. So I was to make surgery. Which surgery I can do here? Generally, till now, there are two types of access. One is suprainguinal, like for the inguinal hernia, yeah, along the ligament. Second is infrainguinal. Sometimes even we do the longitudinal incision, but much more better to make the parallelly to the inguinal to not damage the structures. If you make infrainguinal incision, everything is simple. Yeah? You cut skin, subcutaneous fatty tissue, proper fissure, you see the ligament. By the hooks, you little bit lift it to upwards, you see subinguinal space. And you find the aperture. Inside of this aperture, you see the hernial sac. All another steps is same, guys. You fix the sac, you open sac, you make revision of the sac. If it is alive, you push it to upwards. If it is not alive, you finish here. You make the big laparotomy inside of peritoneal cavity, resection, anastomosis. Okay, now you remove the hernia. What after? Again, methods with the tension, methods without tension, plastical reconstruction. Without tension, plastical reconstruction is simple. You take the mesh, you suture it by the borders of this aperture. Medially, it is Gilbert ligament. Inferiorly, it is pectineus ligament, which is covered the bone. Yeah, and anteriorly, superiorly, it is inguinal ligament. Medially, there are veins. You don't suture it by the vein. But the method with the tension also we can use. Now, simply, what can I do in this aperture? The most simple, what can I imagine? Here there are pectineus ligament, here there are inguinal ligament. I can try to suture these two structures to each other and to decrease the size of this aperture. Method is very simple, but not good. Why it is not good?
With damage, maybe.
No, you don't close it, you just decrease it.
Okay.
But why it is not
Unmovable and
let's say inguinal ligament, which is up and in front, I distend it to down and behind, and suture with the pectineus ligament. What the problem? you see that if in your head no any knowledge, you cannot make any logical complication. If I will descend the inguinal ligament, I will increase the size of the inguinal space.
Okay, yes.
If I will increase the size of inguinal
Yeah,
space,
herniation of.
instead of the femoral hernia, we will have inguinal hernia. You understand it?
Mm.
That's what I do. Much more usually, if you make more surgery with the tension, do suprainguinal incision. Open inguinal canal. Inside of the inguinal, then you will open the inguinal canal, you will see posterior wall of it. It is the transverse fascia. Cut this transverse fascia and become to the Langebeck space. Inside the Langebeck space, you can see this sac, which is passed behind the inguinal ligament and come by this aperture to subinguinal space. Take this sac and push it inside of your inguinal space. Instead of the femoral hernia, you will have inguinal one. Yeah? Now everything you will do the same. But what after? After, guys, the same anterior or posterior wall plastical reconstruction, you remember, needle from the external oblique aponeuros from two muscles, then it come to outside. But you suture it not with inguinal ligament, but by pectineal ligament.
Yes, yes.
Below the inguinal ligament, 1-2 centimeters, you see the pubic bone and the ligament which is covered. Let's say these muscles behind the inguinal ligament, you descend it into the subinguinal space and you suture it with the posterior margin. You understand?
Yes.
Let's say these muscles, like the curtains, will cover and back of the inguinal and subinguinal space. They will make stronger both these spaces. But again, aponeuros will be fused with the aponeuros. That's why you will have strong communication, not muscles with aponeuros, but aponeuros with aponeuros. Questions? Yeah, I forget to say you walls of the inguinal canal. Then during the protrusion it will be formed. Now look, normally this anterior margin of deep ring fused with the superior margin of the superficial ring.
Yes.
Between them there are septas. Posterior margin have the septas which is connected with the cornu inferior. That's a cornu superior fused with the anterior margin, cornu inferior fused with the posterior margin. That's why they located in such kind of the case, but they doesn't have exact communication to each other. Now look, then hernia is happen. Posterior margin generally doesn't move because it is bone, which is covered with. But anterior margin push to in front because you push it. Then you push it, these connections is dilated. And triangular shaped canal is formed. Yeah, why triangular? Medially will be the Gimberland ligament, which is fused. And we will have triangular shaped canal. Laterally will be femoral vein. Anteriorly will be protrusion of the first connection, which is superficial layer of proper fascia.
Yes.
Posteriorly will be protrusion of the second connection, which is deep layer, because fascia iliaca it is deep layer, not fascia pectinea. You understand me or not? That's why instead of the quadrangular shape inguinal canal, you will have triangular shape femoral canal. Superficial layer of proper fascia, deep layer of proper fascia, in sharp angle the Gimberland ligament, laterally will be facial vein, which is located inside of the
Femoral
vein, which is located inside of facial capsule. No anything to add. Let's come.